I'm Michelle Moore-Stern, as she said, with the Bureau of TennCare, and I'm in our Long-Term Services and Supports Division. We have lots of different units. You're probably familiar with some of them: eligibility, provider services, things that you would assume, and then, of course, long-term services and supports, because there are so many different programs that fall under that. And while there are, relatively speaking, when you think about the 1.2 or 1.3 million people who were served by TennCare, and there's less than 40,000 enrolled in long-term services and supports, or about that many, it feels like a really little piece of the population, but it's a very complex piece of the population. They need services that a lot of people don't need. It's very hands-on, very high touch, and can get quite complicated, and is a little bit more costly sometimes than some of the other typical Medicaid services that someone would receive. So we pay a lot of attention to this population and to these programs, and I'm excited to be here to talk with you about them today. So let me see if I can. So a little bit about what we're going to talk about is transitioning into adult TennCare, if you will. So you may be familiar with the early periodic, the EPSDT services that children can receive. So we're going to hit on that very briefly to move into the adult world. And then I'm going to talk about the Choices program, and I'm going to talk about a new program that we're going to launch next year called Employment and Community First Choices. And then I'll talk a little bit about the coordination of benefits in the state's expectations around coordinating benefits for people who receive services. So first we'll talk about transitioning into adult TennCare. So the good news with this is children who may have not been eligible for Medicaid prior to becoming an adult may now be able to qualify for Medicaid as an adult. The reason that some children don't qualify is because they might not fit into one of the medically needy categories that we have, and also primarily because most of the time, their parents' income counts as their resource, especially if the children are living at home with the parents. And so if they don't qualify through the SSI, then they may not qualify for Medicaid. Once the child becomes an adult, which in the system could be between the ages of 18 and 22, depending upon whether or not they're still a full-time student, then the eligibility, the parents' income and the resources aren't counted against them anymore, if you will, for eligibility purposes for that financial determination. The income limits to qualify for Medicare, they do change based on age. And they're also a little bit higher for people who need the long-term services and supports. And if we're all in agreement, I'm going to call that LTSS from now on, so just so that I don't get tripped up on all those extra syllables. So what you need to know about transitioning into what we'll call adult TennCare is that adult Medicaid benefits are different than the benefits that children who do qualify for Medicaid are able to receive. Because under the age of 21, through the early periodic screening, diagnosis, and treatment services, there are things that are covered for children that are not covered under the adult benefit. We allow for things that will ameliorate physical and mental conditions, so children are able to receive more therapeutic type services, more nursing services, more units of services that adults are not able to receive. Once you turn 21 and you qualify for adult Medicaid, you qualify for TennCare, those limits kick into place, and that can include pharmacy benefits, and it can include home health. So talking about those nursing benefits and where some of that comes into play, and you may be able to get that almost around the clock in EPSDT if you qualify for it. That benefit's simply not available as an adult. There is a limit on that. The great news, however, is that once you turn 21, if you have a physical disability, you may qualify for the TennCare Choices program. And I want to spend some time talking about that program that we have today. So Choices eligibility, there's three different things to think about when you think about, okay, I've turned 21, but what else is required for me to be able to be eligible for Choices? So you have to fit into what we call a target population. And the target population for the Choices program is older adults who are 65 and older, which I realize doesn't really qualify for your children transitioning, so we'll focus on the 21 and older with a physical disability. And then there's the medical eligibility piece. So you have to need the level of care that is provided in a nursing facility or be at risk of needing that care if other long-term services and supports were not provided to you. And we also call that HCBS, or home and community-based services. And we'll talk a little bit more about those specific services in a minute. And then, of course, there's the categorical and the financial eligibility. So you always have to meet, these things always have to marry up before your enrollment begins. So you have to qualify for Medicaid in one of the groups that we typically have. And then you also have to meet financial eligibility. And I want you to get your pins out and mark through your notes that says is determined by the Department of Human Services, because that is now determined at the Bureau of TennCare. And I apologize for not catching that. We've been doing that for a year now, and I can't believe that we let this get through. So in addition to that eligibility, in order to receive the Home and Community-Based Services, the HCBS, the care has to be able to be provided safely in that environment, in that home and community-based environment, whether it's the individual's home themselves or an assisted living facility or one of the other home and community-based settings. And it has to be provided safely and at a cost that will not cost more than what it would cost if that person were in a nursing facility. And that's what CMS and what the state calls an individual cost neutrality. So what they look at, what CMS looks for when states are implementing waivers, is that it will be cost neutral. It doesn't always have to demonstrate cost savings. While that benefits the state because it allows them to serve more people, it needs to at least be cost neutral. I mean, if we're going to pay these high prices for institutional or hospitalization type care, and now we're going to provide these services in the community, you need to meet that same, you're getting the same level of care that you need, but it's costing me a lot less. It can't cost more. If it costs the same, we're okay with that, but it can't cost me more than it costs. And there also has to be capacity to enroll under any enrollment targets that may exist depending upon the waiver that someone's trying to enroll in. And in Choices, we do have an enrollment target for what we call Group 2, which is the comprehensive home and community-based service area. We have not met that target. We once, last year, went to a waiting list for just 2 months while we worked out some legislation, and as soon as we got all that squared away, we opened it back up and actually increased the enrollment target. So far, other than that 2-month period of time, we have always been able to increase the target when we needed to, when we saw that we were getting close to the reserved cap. So these are the benefits that I mentioned earlier. So the home and community-based services that are available are based on a comprehensive needs assessment that's done on each individual. So it's not like this is a list that's handed to someone like a menu and said, here, select what you think you need or what you would like to have. It's really, this comprehensive assessment is done by a person's care coordinator that we're going to talk about those requirements as well in just a moment, to determine what you really need. What's being provided now by natural supports, family caregivers, or others who come in to help you, and where are the gaps? Meaning, where do we need to fill in with the paid services? And that's where this comes in. What we want to do is fill in the gaps for you, not supplant what exists, not pay for what's already being provided for free, but make sure that we're not leaving things uncovered out there that would put you at risk of needing institutional care or needing a higher degree of care because we didn't provide what was needed. So we broke these down into some categories just to kind of help think about how the services are used. And we have some what we call hands-on services, so personal care visits and attendant care. By definition, when you look at what those services provide, it's essentially the same thing. It's that kind of help with daily living activities and those things that, you know, the grooming, the bathing, the dressing, transferring, toileting, all of those kinds of functional things that someone might need throughout a day to help them function and stay as independent as possible in their own community. The difference between the two is the personal care visits are reimbursed at a little bit of a higher rate because those are services that are provided at 4-hour intervals or less and have more than 4 hours in between each time that service is provided. So the expectation there is you've got a worker who's going to work maybe 2 to 4 hours in somebody's home and then travel to somebody else's home and potentially do the same thing, and then maybe travel back to the first home or even to a third home and do the same thing. And so you've got a little bit more travel included there. You've got a little bit higher expectation of the requirements around that worker because I'm working shorter shifts. Attendant care is going to be 4 hours or more, or there's less than 4 hours in between the visits. And we typically see attendant care being 4 to 8 hours at a time that are provided for individuals. So we're kind of filling up the bulk of your day, and you might not need that split shift. But for somebody who has a physical disability, who maybe all I need is for you to help me get out of bed in the morning, get me going, and once I'm up and going, I'm good, I'm pretty independent, or I have natural supports that are assisting me. But when nighttime rolls around, I might need you to come back and help me with dinner and or help me with my routine for getting back into bed. And so you don't need somebody with you 12, 14 hours a day to sit around and wait to help you again in the evening. That person can go and maybe, do other things, work for somebody else for a little while, and come back in the evening and help you with your evening routine. And then we think about caregiver assistance. So adult day services is exactly that. An adult will go to a day program where they can participate with other people who were there. They can get some socialization activities, maybe some other types of activities. We're working really hard right now to come into compliance with some new federal rules around person-centered planning and HCBS settings, where people are making sure that people are as integrated as possible and as integrated as they want to be in their communities. So this will allow, if you're an adult child caring for a parent, for example, it allows you to bring your mother or father to that adult day service, and maybe you have a job that you can go tend to, or other activities or errands that you need to do during the day. And then, of course, respite. We have in-home respite and inpatient respite, and that is to provide relief to that primary caregiver. We want to do what we can to support families who are able to provide that in-home care and have that loved one who lives with them. And we want to look at how do we do that in a way that keeps them from getting burnt out and having to make that next step to moving the person out or looking for other services. So we want to wrap around them what they need to be successful there for as long as possible. The day comes when people can't do it anymore, or someone's needs are so great that they can't be met in that situation anymore, and we'll make those decisions. But what can we do to prevent that or delay it, at least for as long as possible? And then we have a few community-based residential alternatives, CBRAs, and these are residential alternatives to nursing facilities. And so we have assisted care living facility, which can be reimbursed as an HCBS service. We have what we call adult care homes, and through legislation, these are all level 2 care homes, meaning that they're more critical care. And we have 2 populations of people for whom we have authority, both federal and state authority, to provide care to, and those are people who are ventilator dependent and people who have traumatic brain injury. So there are just a few of these homes in the state, and they are specifically for those populations. And then we have companion care. Companion care is exclusively consumer directed. Anybody in here know what consumer direction or consumer directed services mean? A couple of people? Okay, so consumer direction, and we'll talk about this again too, so you'll pass the test at the end when we get to that part. Consumer direction means I'm not going to use an agency to provide a worker to me to come into my home who's employed by that agency. I'm going to employ an individual. I'm going to do that research. The state contracts, we contract with the fiscal employer agent to help you identify people if you need that assistance. Some people don't. They already know who they want to hire. They've got good workers lined up. And I want to employ that person. And the person really is the employer of record, if you will, except when it comes to payroll and tax filing responsibilities. We don't want you to have to do that. And we don't want to have to do that. So we've contracted with a fiscal employer agent who does that on behalf of the individuals and handles all of that with the IRS. So they pay the individuals as if it's coming from a provider agency, but you're technically the employer of record. They're your employee, but we're handling all that payroll management stuff for you. You just have to manage your employee. So it really helps you to focus more on the care and the services that are needed as opposed to the financial piece around being an employer. But companion care is a 24-hour residential service for people who need intermittent care, not hands-on care 24 hours a day. That's not really appropriate for that because no one person can do that on an ongoing basis. And so this is really for someone who needs that intermittent care. So the person moves into the member's home and lives with them there to provide that care 24/7, as needed. And it's all written up in the plan of care and agreed upon as to how much care is needed and when it's needed and how it's going to be done. And some other support services are home-delivered meals, personal emergency response systems, assistive technology, minor home modifications, and pest control. And so while those aren't necessarily hands-on, they can be very significant when it comes to ensuring somebody's safety or ensuring that someone is living in a nice, safe, sanitary environment in the community. So pest control can be really big, especially when you're looking at older people who maybe live alone and they don't think about those kinds of things. They certainly don't need an infestation. So I talked about consumer direction. So we'll talk a little bit about care coordination. I mentioned that the services are determined based on that comprehensive needs assessment that is conducted by the care coordinator. And so whenever someone is enrolled in Choices, they are all assigned their own care coordinator. And the qualifications for being a care coordinator, you have to be a licensed or registered nurse, and or you have to be a licensed social worker. So we have pretty high criteria, and all of the managed care organizations employ nurses and social workers to play that care management, care coordination function for the Choices program. So aside from that comprehensive needs assessment that they do initially to determine that first plan of care and which services are most appropriate, they do that on an ongoing basis as well. And we do that through what's called a person-centered planning process. And especially in line with the new federal rules, the member or their representative, as appropriate, really needs to drive that process. It's not about an agency coming in saying, here's what I think you need, here's when we're going to provide it, so this is the time of day you have to get up, and this is the time of day we're going to come back and put you to bed. It really needs to be about what the member needs, not only to meet those activities of daily living requirements, but also to allow them to have a quality of life that they are wanting, which is the reason most of our membership wants to be in their own homes rather than in an institutional setting. So the care coordinator is responsible for the coordination of physical, behavioral, functional, and social support needs. So just to step back for a little bit, I think everybody is aware that TennCare contracts with 3 different managed care organizations: AmeriGroup, Blue Care, and United Healthcare. We have been contracted with managed care organizations since, I believe, 1994 to coordinate physical and behavioral health services. All long-term services were outside of that umbrella, and that was done what's called fee-for-service, meaning they dealt directly and contracted directly with TennCare. And the managed care organizations, we contracted with them for physical and behavioral health. Well, in 2008, the legislation was passed to implement the Choices program. We went live in 2010, and what we did was we brought that LTSS component up underneath the managed care umbrella, because we wanted the care coordinator, we wanted the managed care organizations looking at the person holistically. That way we don't have somebody in the organization authorizing home health or nursing or certain services, and then we've got them in a separate fee-for-service waiver over here who's providing personal care and attendant care, and we're not talking to each other about what's going on. So now that's one person. And that one person, that one social worker or nurse, has access to a whole clinical team who helps them with any other expertise that they may need. Because every nurse and every social worker is not necessarily going to be a behavioral health expert or even necessarily a physical health expert, but they're going to bring their expertise to that process, and they're going to be able to tap into the expertise that their health plan has to help make sure they're building the appropriate care plan around each individual. So that they also manage the chronic conditions and any care transitions between care settings or types of services that are needed. And they do that on the ground, face-to-face work. So this is the person that you develop that rapport and that relationship with. They're required, once they get through that plan of care process, that front-end stuff, I'm sure you know, is a little bit, that's a little heavier, that's a little more labor-intensive, takes a little longer, and you have a little bit more frequent interaction through that process until your services are in place. And then that care coordinator is required to contact that member or family once a month by phone, at a minimum, and then to visit them face-to-face in their residence at least once a quarter. They can do that more often as required, and that can be determined between the care coordinator and the member or their family as to what that person's needs are. We have detailed requirements and protocols. We have our contract with the MCOs is called a Contractor Risk Agreement, a CRA we call it. And we have, I think, 51 pages dedicated specifically to the state's requirements around care coordination expectations. Most states, when we were developing our program and we started to look at other states, we found about 3 or 4 pages. We have 51 pages in our CRA, and I think we have 36 or 37 protocols that support the CRA to help the managed care organizations and their care coordinators understand how to do, what's the step-by-step of what that requirement is in the COA. It really provides that guidance and the expectations and kind of helps paint the picture of here's what we mean by these expectations and these requirements. And then, of course, the continuous monitoring and oversight of compliance. We do that through the LTSS unit. We also do that through a unit at the Bureau called Quality Oversight. And so they really look at the care planning process. They make sure that timelines are met. They make sure that people are receiving their contacts when necessary and required. And then it also gives us line of sight into the services are being provided when they're supposed to be and people's quality of life. So the ongoing comprehensive care coordination, it really is, it's the cornerstone, and you'll hear the managed care organizations talk about this too. It's key to the success of the program, because if you don't have care coordination that is functioning the way that it should, then you've got people who aren't getting services that they need, or they're not getting them the way they need them when they need them, and you've got families who are in disarray, and you've got caregivers who are stressed out. But if you've got a care coordinator who's helping to manage all of that health care and those long-term needs that people have, then you really have this much more holistic, comprehensive approach to health care. And this is a really interesting time that we're in, because we're seeing, and Elise McMillan walking in the room, a very friendly face, reminding me where health care meets housing and where health care meets employment. And this state is really working with a lot of different groups about how do all of these things belong together? When did Medicaid get into the housing business? And when did Medicaid get into the employment business? Well, let me tell you, we're in the business. We are really working with these groups and working with people because we can do things from a policy perspective that make it easier for the community to provide these types of supports. So that's where all of that is kind of driven from. So the care coordinator conducts that needs assessment, that initial comprehensive needs assessment that I talked about. They'll do that on an annual basis. And they'll also do it if there's ever been a significant change in someone's life, if you're hospitalized, or if they become aware of an illness or a chronic condition or something that's happened. I've had a fall, or I've had a significant injury or illness. Then that care coordinator will reassess to say, okay, things with you have changed. Does that mean that what we put in place prior to this is still appropriate, or does that need to change too? And so all of that happens as it needs to. And the plan of care gets updated. It doesn't have to be annually. It may be more frequent than that, depending upon the needs of each member. The MCOs monitor service delivery through what we call an electronic visit verification system, or the EVV system. And it really gives them real-time line of sight into services being delivered when they're supposed to be delivered, because it's a call-in system, and there's a dashboard, and there's red, and there's green, and there's purple, and there's things that indicate to the MCO somebody's late. Somebody's missed a visit, and alerts go off, and they start calling people. They say, I show that you were supposed to receive services at 8 o'clock and no one's called in yet. Is your worker there? Oh, yeah, she's here, but I was on the phone with my sister and I didn't let her call in. We get a lot of that, but it gives you that real time, what's happening with this member? Are we sure that they're getting the services that they need? Are we sure that they're not laying in the bed unattended, or that something has happened to them and they're unattended? And it gives that MCO immediate, real time line of sight into the service provision. And then the care coordination with natural supports and community organizations. So your care coordinators, they really make it their business to be informed about what's available in the community. What's going on in the community? What might you be interested in? And as they get to know the members and get to know their families and their interests and their needs, it helps them to think about what else is available besides these paid services that might benefit you or that you might be interested in. They really work with individuals on being able to branch out or tap into those other types of community resources. So I talked about the minimum contact requirements already. So now I'm going to move into a new program that we are looking to launch next summer, July of 2016, and it's called Employment and Community First Choices. So who is this program for? This is going to be for people who have an intellectual and other types of developmental disabilities who are not currently receiving services. You all may be familiar with the Department of Intellectual and Developmental Disabilities and the three, what we call 1915C state waivers that we have where we serve people with intellectual disabilities. We do not in this state today serve people with developmental disabilities. So for those of you who may be parents or advocates or physicians of people with developmental disabilities, you are likely painfully aware of this. So unless you qualify for TennCare and you get some Medicaid benefits covered, we don't otherwise have programs like waiver programs, like the ID programs or the Choices program I just talked about, available for people who have a developmental disability that's not an intellectual disability. And we're changing that. So this is going to be part of this new program. So people who are in those ID waivers today will be given the opportunity to voluntarily transition over to the new program once we get the program up and running. So we'll probably make sure that it's on its feet for about 6 to 12 months and then open it up for people to transition over if they want to. So this program is going to offer support for families who are caring for someone who has an intellectual or developmental disability, and supports for people who have a disability who want to achieve employment or who want to improve their independent living skills, prepare themselves for that, or do that successfully. How are we going to help them meet their goals? And then for people who cannot work, because just because employment is in the name and it's the first part of the name, it's not a requirement. And there was a lot of concern about that when the concept paper first came out. But there are people who are of retirement age who want to do retirement activities instead. And just like you and I should be able to do that, people with an intellectual or developmental disability should be able to make that choice as well. Or if for other reasons they cannot work, there will still be services available in this waiver to support them with their community needs and any other residential needs that they might have as well. We're going to have what we call 3 different benefit packages in this program, and the first one is called Essential Family Supports. This is going to support families with a child under the age of 21 who has an intellectual or developmental disability to continue to support that child in the home. And it's going to help families to prepare for the transition when that time comes into adulthood and what's next, what's after school, or what's after you don't live with me anymore. How do I prepare you for what's coming next in regards to employment and living independently as I prepare for adulthood? Now, we are also in this benefit package going to provide supports for people over the age of 21 who live with their families. We don't want to make it look like you turn 21, you're going to have to move out of mom's house. While some of us raise our children towards that goal, not everybody does. And so we have a lot of families in this state caring for adults with disabilities in their homes, and they want to continue to do that. We want to be able to support them in doing that. And so this benefit package is also going to be open for adults who live in a family home, and we need to support that family in being able to continue to provide their care. Essential supports for employment and independent living. So this will be for adults over the age of 21 with a disability, and it will help people in that transition group from transition from school and into adulthood, and adults of all ages who are looking for employment opportunities and looking to achieve their employment goals. How are we going to help them do that? So we're building services into this package to help people obtain those goals, and also to help them obtain any independent living goals that they may have. So this benefit package has residential services in it for people who don't need 24-hour care. If you're familiar with the residential programs in the ID waivers today, then you know primarily what we do is we wrap 24-hour care, 24-hour services around people in a residential program. Not everybody needs that. Even if you have an intellectual or developmental disability, you don't necessarily need that. And so this benefit package will provide residential supports for people who don't need care around the clock 24/7. Maybe I need access to somebody 24/7, but so do I, right? That's why we have family members and 911. So, there will be a built-in resource for that if they needed access to emergency services. And the third package is called Comprehensive Supports for Employment and Community Living Services. So this is for adults 21 and older who have more intensive needs than the group that we might have just talked about. So maybe they need 24-hour residential services. If I'm going to have an independent living goal, mine might require 24 hours. I may have more medical or behavioral needs that won't be addressed adequately in one of the other benefit packages. This benefit package will address those needs so that we can still help you work towards any employment or independent living goals that you may have while meeting any medical or behavioral needs that you have as well. There's also going to be a few more choices about how services are delivered in the Employment and Community First Choices program. And that will be through consumer direction. So I talked about that when we were talking about the choices benefits. and how the person is in charge of that, and the state contracts with the fiscal employer agent. So this really means in this program, the person's in charge of their budget, and they are basing, the needs based on my budget. I've got to make my service needs fit within this budget that I've been allotted by the state. And again, we will maintain that contract with the fiscal employer agent so that the member or their family member or their representatives don't have to worry about that payroll and tax filing and all those things that, not to speak for everybody, but that I know that I wouldn't want to have to be responsible for, and a lot of people that we come across don't want to be responsible for it either. In addition to other options for how services will be available or be able to be provided in the new program, for people who have more needs and qualify for that third benefit package of comprehensive supports, there's going to be an option where people can choose to have a provider really help to manage their budget and all of their services. So it's kind of a mix between consumer direction and health home services, not home health, but health home, where you've got one provider who really kind of looks at everything that you need, and they coordinate all of that for you. It will still include being able to choose who your service providers are. It will still require coordination with that care coordinator with the MCO, because they are going to still be responsible for that plan of care and that comprehensive needs assessment. And these two entities will be working very closely together on managing and monitoring this individual's needs. So this will be people who fit into that third benefit package and have more intensive needs. So how is the whole overall program going to be managed? It's going to be managed very similarly to the way that Choices is managed today. We are going to utilize our managed care organizations that we have contracts with today to coordinate the services for people in the new program design. And that will include the care coordination as I've described it earlier. So everybody will have a care coordinator assigned to them to help them with their HCBS. And remember that umbrella, that physical and behavioral health, all of it's going to fit up under that umbrella. We're looking at the person holistically in this program too. DIDD is also going to play an important role in this program as well. They have very intense quality monitoring processes in place for their services and their providers, and we're going to carry a lot of that over into this program to make sure that the quality of services is maintained and to make sure that people's quality of life is maintained as well and the expectations are met there. So we're working really closely with them, and we have been working closely with them since we started the development of this concept paper. This has been about a 1.5-year project going on, yeah, so we've been doing this for a while. So here's the hard part. How are the participants going to be selected? So when we roll out with this in July of 2016, enrollment into the current ID waivers is going to close, and all new enrollment will be directed into this new program. If you're familiar at all with the DIDD services, then you may be familiar with their waiting list that they have as well. And there are a lot of people with intellectual disabilities on that waiting list waiting to receive services. There are probably as many people with developmental disabilities who aren't on a waiting list anywhere because we don't have a waiting list for them to qualify to be on right now. So we don't even know today how to identify them. We know that they're out there, but we couldn't tell you who they are. And so we really need help figuring this piece out, because we really have to, and we've been seeking input and asking for it for about 1 year now, because when we went across the state to meet with providers, consumers, family members, people who are receiving services today and people who are on the waiting list today, and family members of people who have developmental disabilities so they're not on a waiting list, what we heard over and over again were 2 different groups of people that we needed to focus on, and one was the transitioning youth. I think we heard that more predominantly than any other. But the second that we heard almost as much were older adults with aging caregivers. So that's something too, because if I've always been at home and I'm an older adult and my caregivers are aging and something happens to them, I'm suddenly transitioning into something potentially very different than what I know today. So how are we making sure that everyone's prepared for that? So focusing on these 2 groups, how do we find them? We're not going to be able to just open this up and clear out that waiting list. Number one, there's no funds for that. So this is definitely going to be a slow trickle into this new program. And any new funds that we do receive or are able to allocate, we will allocate towards enrollment into the new program. Once we get going, and I talked about people in the current programs being able to transition into the new program, if they choose to, the money that's serving them in that program will move into this new service system. as opposed to staying in that service system. So that'll kind of be the money coming with you if you're already in the system. But if you're not in the system, we're having to use existing funds and look for resources where we're able to identify other savings to serve people. So as you think about this, and if you think about ways that we can identify individuals and make it fair and equitable for how we roll people in so that other groups of people don't feel like we're discriminating against them or leaving them out of the enrollment process, please submit your ideas to us. We are really trying to work with lawyers and with advocates and with families on how do we do this in a fair and equitable way. I think I've probably covered all my bullet points here. You can tell we've been talking about this a lot, so I tend to slip through the slides. So I don't know if you received this electronically or not, but it is in the handout, and if you get this electronically, you can just click on this. This will take you directly to the concept paper that we wrote that really goes into detail about our ideas for the new program. Remember now, that's a concept paper, so there have already been a few changes. For example, in the essential family supports, we really identified in the concept paper that that wouldn't serve anyone over the age of 21, but we've already opened up to the fact that we're going to do that. And if this requires what's called a waiver amendment, so as part of that TennCare waiver that we have to amend that in order to provide these services, and we're working with CMS on that now and blowing out those service definitions and getting prepared to submit that to CMS. And so we've made some tweaks. So when it's called Amendment 27, so when that posts, because it has to post for public comment, so pay attention to communications about that because you'll want to review Amendment 27 and provide comments to us on how we can make it better before we finalize it for implementation. So this is a little bit about our expectations for the coordination of benefits prior to someone turning 21 years old. So if the individual, I kind of broke this into different categories. So if the individual is in a DIDD waiver today, remember they have an MCO, because if you're in a waiver, you have to be Medicaid eligible, so you have to have an MCO, because everyone on TennCare or Medicaid has an MCO. So their MCO and their independent support coordinator have to assess the individual's needs together, and we have developed contract requirements and protocols around our expectations for this, and contact people at each agency so that they know who to contact when they all realize they have a member who's approaching their 21st birthday. Then they all need to get together and assess the individual's needs, because if I'm turning 21 and I currently get EPSDT, I may be getting a lot of stuff that I'm not going to be able to get when I turn 21. And if I'm in a DIDD waiver, then what we need to look at is what can the MCO pay for, and then what does the waiver need to pick up. And remember, we're just trying to fill gaps. We're not trying to supplant natural supports. And that's a real hard line to distinguish sometimes, but it's a very important one. And so we do have requirements around that happening. And part of this process, the MCO and the ISC need to prepare the family for things are going to change. This is going to be different. You may not, if you're getting 24-hour services today, short of a residential component, you're not going to get 24-hour services after the 21st birthday. So what needs to be in place to make sure your needs are still safely met in the home and that your family can still provide the support that you need if in that home is where everyone chooses for you to stay? If the individual is not currently in a waiver, but they are Medicaid eligible, then you'll want to contact your managed care organization. So today, if you're on Medicaid and you're not in a waiver program of any type, that person has a case manager, kind of like we do. You don't really talk to your insurance company every day, but if you're hospitalized, they're sure calling you up, asking you how you're doing and when you're going home and what do you need when you get home and all that stuff. So reach out to that MCO, and what you need to do is tell them that you're turning 21 and you want an assessment, and you also want a screening for choices. Because remember, we're turning 21. If we also have a physical disability, we might be eligible for the Choices program, and that might help be able to pick up some of the services that aren't going to be available to the individual anymore upon their 21st birthday. So there'll be a phone screening done. If it's determined through that the person may be eligible, or it's difficult to determine through the phone screening if the person would be eligible for Choices, then a home visit is scheduled. And the MCO goes out and they do that functional assessment, that comprehensive needs assessment and a functional assessment to see if you would be eligible for Choices based on your needs. And that is all submitted to TennCare, LTSS, the department that I work in. It goes into our operations department, and we employ nurses who are what's called PAE nurses, they determine the disposition of the prior admission evaluation screenings that are done, and that is what determines approval for enrollment into the program and which type of choices group you'll be enrolled in or be eligible for. And remember, there's a couple of groups. One is that you need nursing facility care and you meet that requirement, and the other is you would be at risk if there weren't some HCBS provided to you. If the individual does not meet the choices eligibility criteria, then the MCO conducts a face-to-face assessment to determine the appropriate level of home health or nursing services that might be needed in addition to any other TennCare benefits to help the individual as medically necessary and appropriate once they turn 21 to ensure that their needs can be safely met in the community. Something that people have to prepare for is providers might change. And what we see a lot, especially if you're a child getting a lot of nursing services in a day, each day, you've probably had the same nurse for a very long time, or the same couple of nurses for a very long time. And upon your 21st birthday, you don't really want to let go of that person. So we have a lot of families fighting to continue in those services. It's not sustainable, and it's not always appropriate either. And so if we can provide other services more cost effectively and still meet the individual's needs, we really need families to be prepared for that and open to that and willing to explore what the future is for their family and for their adult child that they're caring for. So providers might change. You may not get to keep that nurse depending upon what kind of nursing services you would still be eligible for. You may move into personal care or attendant care type services, and that'll be a completely different person, because those workers don't have to be licensed workers, especially if the needs that you have are not skilled nursing type needs.